Okay, thank you, Jimmy. Good morning, everyone. Good afternoon, wherever you are. Today is seminar number 4, webinar number 4. So we are going to repeat what I have been telling you for the past 3 weeks and add some more information for you to practice. I think it would be better if you participate and practice with me, such as mock interviews, case presentations. We are going to do that today. But just to recap, for what we have done for the past 3 weeks is first, I hope all of you have read all the websites of ECFMG, ERAS, National Match, etc., because there is a ton of information in it, and you need to be familiar with all the rules and regulations. I told you that all of you, I don't know you personally, but all of you are absolutely capable of going through the process and get a residency program of your choice. But you have to work at it. You need to prepare for a long period of time. Most students, doctors underestimate how much preparation you need to do. It doesn't matter what country are you coming from. It doesn't matter what medical school you are coming from. There are a few things which are important, which you already know, and I'm not going to repeat, such as your scores. Scores are important, but they are not fatal. If you pass with the first attempt, that is important. So try your best not to fail the exam, step 1 and step 2. Step 1 is pass fail, easy to go through. Step 2 has a number. Higher the number, better your chances of getting an interview. And we are going to spend a lot of time today on interview. We did spend some time last time. We had some mock interviews, 6 of them. I hope you learned something from there. I also want to hear from you whether you have developed or begin to develop a personal portfolio. Remember that all of you struggle very hard to get a letter of recommendation. It's important, and I think a good letter of recommendation, genuine, truthful, will take you ahead. But more important is your work. You need to show the program director what you are capable of. And for that, we created 10 years ago, where I was, we created a concept of a personal portfolio where, let's say you did a observership for 2 weeks. You write down everything you did and what you observed. Remember that in observerships, legally, you're not allowed to interact with patients. You're not allowed to open the chart, the electronic medical record, and you're not allowed to talk to the patient and touch the patient. It's absurd, but that's the law, and we cannot bypass the law. So what you do, power of observation can be shown by writing it down, what you observe. So if you observed a patient with A, B, and C, you write it down, you go to the reference library, look it up. If it is a case of lead poisoning, look it up, write down something about lead poisoning. Nobody is going to stop you from there. And you create a portfolio so that when the program director during the interview sees your work, is highly impressed. And I hope you have it. If you want to send it to me electronically, I'll be happy to review it and give you some guidance as to what needs to be done more. The interview process will take 3 minutes for the program director to decide whether you are acceptable or not. 3 minutes. Keep that in mind. There is no time for you to waste on asking questions which are of no significance. So you need to practice. You cannot just come up with questions at that time. So the first question is, when you interview with a, let's say, program X, you need to know upfront what is that X is. Every X is different. Hospital in New Jersey is different from a hospital in Chicago or a hospital in Florida. So you need to do a little bit of research, maybe half an hour of Googling and finding out what the institution stands for. And bring it up during the interview that you have done that. Because that shows your interest in the program. If the program director's name you know and you should know, look him up or her up and find out what they have done. They may have published something which you need to know, and you can then bring it up during the interview process. I made a plea for you to improve your speech. And I'm not talking about Spanish, I'm talking about English. We all who come from Southeast Asia believe wrongly that we speak very good English. We don't. I can tell you that. I have been here for 60 some years, and I've been always impressed by the lack of understanding international graduates have regarding their speech. They assume that they speak very good English. We write good English, but we don't speak good English. Accent, verb use, diction, etc. And that requires time, energy, and certain formal programs. I gave you a couple of programs which you need to look at. They are inexpensive. They will practice with you, um, and you will improve your speech. Listen to the television show every day, the news. Turn off the volume and see how the news anchor talks, facial expression, because that's what, remember that 80% of your speech is non-verbal. Only 20% is verbal. What I'm telling you is verbal. But what you are seeing me is non-verbal. And you need to master that skill. Confident, fluent, and natural. Don't be scripted. If you're scripted, they will find out. I also told you that it is absolutely essential to learn Spanish. And I gave you a website, Maximo Nivel. I hope you have looked into this. Everybody gets sort of intimidated going to Costa Rica or Peru or Guatemala. You came 10,000 miles from home. So what is the big deal about spending 1 month or 2 months in Costa Rica? It's a beautiful country. They will treat you very well. Do not have a personal experience, but from what I know through others, it is something very positive and it will help you throughout your life, not just for residency. Because you will be applying for different jobs at different time. The English speaking site is called Toastmaster. So Google it, go to Toastmaster website. It is not expensive. It is not cheap either, but it is not expensive. And I would hope that you would use that. It is available in every country, in every big city. It is available on Zoom. It's available live. If there is a university in your town where you live, it is very easy to spot it. So I would recommend that you join Toastmaster and attend as many meetings as possible. Learn to listen. When they interview you, remember, again, I'm telling you, you have 3 minutes to make an impression. 3 minutes. Your fate, yes or no, is decided in first 3 minutes of how you present yourself. So the first question will be, tell me about yourself. So do you want to practice? We did last time a little bit, but do you want to practice now? If you are interviewing with me and I ask you, okay, Gaurav, tell me about yourself. Start. You can't freeze. You have to talk.
Okay. So my name is Dhruval. I have completed my graduation from Bukovina State Medical University, Ukraine. I belong from like small village which is nearby Anand district, and I am the only doctor from my village, and uh, also I believe in
Okay, you are freezing up. You need more practice. Don't be upset.
okay.
There's no reason to be upset about it.
It
This is
was
what I want you to do in front of me, so that when you go for the real interview, you will not do this. You should be fluent, natural. It's like physiology. It is not pathology. Keep this in mind. It is all physiology, but physiology doesn't come unless you practice. So have a friend, hopefully a senior friend, who will listen to you. Have a time clock so that you know exactly how much time you are, because sometimes when we speak, we do not realize how much time we have spent. And
right.
remove all redundant expression. Now you said you are from a small village near Anand,
Mhm.
right? That's what you said. Is
Yes.
it necessary to say that?
No,
You
yes.
wasted 5 seconds.
Mm,
Remember, you got 3 minutes. It's
right.
not necessary. I don't know where Anand is. Even if I knew, does it have any utility? No.
Okay.
So I come from a small village. I'm the first doctor in my town. That would be fine. That doesn't identify any location. Okay? What else you want to tell?
Uh,
Tell me about yourself.
yeah. So also I'm doing my master's in public health in a New York, New Rochelle, the Monroe University, and also I have interest in research. I have done some.
Oh, slow down, slow down. You haven't finished anything about public health, which is a wonderful thing. And
Okay.
all of you listen to me and should consider doing an MPH in a university in US, if possible. It's possible. I can tell you that at least 3 dozen of my residents, I was thinking about it last time, 3 dozen of my residents have done MPH or MHA. It's doable, but you have to put more time into it and money into it. But you are spending money anyway. You are spending time anyway. So why not get a real good MPH, such as Harvard or Yale? Now you think that you may not be the right person for Harvard. You are. I'm telling you. You are. And if I were your age, and if I knew what I know now, I would have done a PhD in public health. Oh my God, that is 4 years. So what? You are in your 20s, right? Mid 20s, all of you, probably. Maybe early 30s, but mid 20s. So you had 4 years. You are still 35. That's a bargain. So don't be afraid. Oh my God, how many years do I have to spend? Your family will tell you, how long are you going to study? It's not study. It is to make yourself a better doctor, so that 10 years from now, somebody will recognize that and give you the appropriate position. That's the whole idea. And don't get hung up with specialty. Do not bring up specialty during interview unless they ask, because you are interviewing for internal medicine residency. They don't want to hear that you want to be a cardiologist. It's premature. Same thing about research. A lot of students now, like you, are doing this so-called mining research. You know what I'm talking about? They buy a program from the government, $120 or so. They will give you 150,000 cases of atrial fibrillation, the data. So, and then you dig into it and you create a paper. Completely useless in my mind. Now, this is my opinion. Some program directors may like it. I do not, because you haven't become an expert in atrial fibrillation yet. So you cannot really mine the data on atrial fibrillation and create a paper. It's bogus. So do your original research, but when you do research, be consistent. So in medical school, for example, have you done any research, Duro, in medical school?
In medical school, no.
Okay. Any one of you have done any research in medical school? It's okay. There is no harm. But
Yes,
let's say
doctor.
you did something. You did vaccination. Okay, many medical students do camps. They go to villages and vaccinate people. I'm sure you have done that, part of training. So when you are doing research now, you can act and say that since I did vaccination work in medical school, I would like to continue that work in residency. Because that creates a link in your thinking process that you are interested in preventive medicine. And then when you throw in MPH, Masters in Public Health, it immediately makes a lot of sense. There are connections. And you need to think about what connections you are going to present. And that's what your CVs will reflect. And your ERA's application will reflect. Don't do one paper here, an abstract, another paper there, totally unconnected with the first one. It should be connected. That's the important thing to do. And I told you this last time and before, to do meaningful research, you need to invest a lot of time. How much time? Anybody knows? How much time do you really think you should invest in research? Serious research. 3 to 5 years. 1 month rotation at Mayo Clinic in the research lab is simply not sufficient. You'll be doing scut work, you'll be packaging blood samples and sending FedEx, but that is not research. You have to give 3, 4 years of your life into minimum 3 years. Keep this in mind. Now that may sound impossible at your age, but it's not. It can be done. In my website, you will see a profile of a Dr. Dukas.
Yes.
Dr. Dukas is a Greek physician, went to a school in Eastern Europe, medical school, started to do during summer months research at Yale University, just come in summer, do research, go back home, became my resident, and he took time off. Whenever he had time off, like a weekend off, he would drive to Yale, which is about 2.5 hours, do his work Saturday, Sunday, come back late Sunday night, Monday morning, and do his residency. And 2 months ago, he got his PhD. Think about that. The amount of industry and energy he spent, he is now a PhD. And he's going to be, he is a GI fellow in our program. And in the next 5 years, you're going to see his name all over. But that is the kind of research you want to do, not writing an abstract, mining data, etc. Coming back to interview, make sure that your internet connections are absolutely solid. You have no idea how many people have failed connections. If you fail connections, they are not going to wait for you for more than 5 minutes. The secretary will cut you off and say, come back. And you will never come back. Remove all the distractions from your background. Your background should be plain, simple. Don't try to show them that you're interested in A, B, or C. It's not necessary. We know who you are. Be on time. Do not be late. You don't want program director and his faculty to wait for you when you are not present. So be early on time, 5 minutes before. Just make sure you are there. Make sure your mic works. Make sure your dress is appropriate. I would recommend a tie, a clean shirt. White coat is not necessary because you are not in a clinical area. But make sure that it is not distracted. There is no noise, kids running around, cats, dogs running around, barking. You need to make sure that it is absolutely quiet your time. Listen carefully what they ask and answer that question. Do not divert. You probably prepare yourself for the interview and you develop a script what to say. All of us do that. It's okay. But it should be appropriately timed. They have to ask you that question for you to answer that question according to your preparation. If it doesn't fit, don't deliver it. just make a new answer. They don't ask you tough questions. Remember that the interview process is testing only one thing, and that is interpersonal skills. They are not testing your medical knowledge, they already know who you are. They have your USMLE scores. They are not testing your clinical sense because there is no way to test it. And I'm coming back to that, the clinical skills. They are not testing anything other than your interpersonal skill. How you talk, how you deliver a message, how you react to a situation. So let me ask you a question. I asked you, tell me about yourself, and you sort of hesitated, but you should be prepared for that. So let's take somebody else. Okay, Dr. Singh, am I seeing you?
Yes, sir. Good morning, sir. Good
Okay, good
afternoon.
morning. Do you want to tell me a memorable case you took care of, you being present there? Anything worth
Uh,
remembering?
um, sure, sir. So I haven't prepared anything specifically for this, but off the top of the mind, a memorable case that I encountered during my internship was a case of a burns patient. So basically, the patient when okay, no, sorry. Can I change? Can I start over? I have
Sure.
another case. Sorry.
Yep.
So yeah, so I'll like to start over with
No,
another
that should
case.
not
So this
happen.
case,
Listen,
yeah,
that should not happen during interview.
yes,
You
sir.
should be
True.
prepared. Okay, go ahead.
Mhm. So there
Now,
was this
what
case
is
that
in
I
the
saw.
background? Wait. Let me stop you here. There's a lot of stuff hanging on in the background. What is it?
Oh, sir, it's just curtain in my background, like
Okay,
covering the window.
it's distracting. Okay, that's all right. And what
Okay.
is on your right?
Sir, it's just I'll turn it to this side. It's just a gate, like
Okay,
it's the
all
exit
right.
of the
Make
room.
sure it is clean. On your
Okay,
left
sir.
is a clean space. I would recommend that
Like
on your
turning
left.
this way. Okay.
Yeah. That
Okay.
looks much better. Okay, go ahead.
Okay. So the case that I saw during my internal medicine posting during my internship was of he was he was a middle-aged guy, like he was in early 30s, who came to us with the complaints of
Wait a
constipation.
minute. Are you calling a 30-year-old man middle age?
No, sir, middle 30, mid 30s, I said.
But you
Mid
said middle
30s.
age. Okay, be
Oh, no,
careful
sorry. I meant, yes, sir.
because
I meant a mid 30s.
our standards back home are different.
Hmm.
50 is middle age in India, for example, or old age, retirement age. 50 is
Hmm.
a teenager in America. So be careful of what word you use. And this may seem to you very trivial, as though I'm picking on you. I'm not picking on you
Okay.
because impressions
Okay.
are made by words. So you
Hmm.
need to be very careful. Go ahead.
So, sir, he came in with the complete complaints of constant abdominal pain, and apart from that, he was feeling very fatigued, and he also had dizziness. So, when we started his workup for abdominal pain, we went through system by system, going through his GI system, going through his cardiac system, his respiratory system, and he was by occupation, he was just a labor worker, like he was an everyday labor wager. Uh, there was nothing there was nothing like nothing remarkable coming out in his labs. All of his everything on his physical examination was normal, and during his labs his hemoglobin was
Okay. One problem we all have, including me, we speak too fast. You're
okay.
talking in Hindi with me now. You're not talking in English. You
Hmm.
have to slow down. I have difficulty after 60 years to slow down. Not easy because I speak Gujarati and
Hmm.
my English comes with a tainted with Gujarati a little bit. I try not to, but it does to the American voice who is listening, it creates an impression. Keep this in
Okay.
mind. So slowly, deliberately, every word has to be used carefully. Okay, now you said
Okay.
you went to the labs first before you said about physical. So don't you think you should have said something about history and physical first?
Yes, sir.
That is tradition, right? So what
Hmm.
did you find on history and physical?
Sir, in history, he did not have any significant past medical history or any surgical history. There was history in his social history. There was drinking of occasional alcohol drinking, but it was just around 40 to 50 mLs once or twice a month. So it wasn't even anything major. He did not have any other kind of social history or any history of smoking or anything like that. When we performed a physical exam on him, he looked pretty lethargic and he looked cachectic. I shouldn't be using that word, but he was pretty thin and frail for his age group of person, and it looked like he was underweight. Uh,
Shouldn't you have
so
told
on
me, shouldn't you have told me that he had a weight loss in history?
he didn't say any weight loss history,
Okay.
sir. He didn't
Okay.
mention any weight loss
Okay.
history.
That's fine. That's fine.
Yeah.
But you
So
you 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 saw that he was cacactic. Okay. Good.
Yeah, and when we asked him, he was like his body built is that way because he's a laborer. So that's why it was assumed that he wasn't eating a stable diet for pretty long. So that's what we assumed initially. And then the only and while examining his abdomen, he had a very generalized pain, and it wasn't anything specific. It did not radiate. It did not have any features of anything that was alarming.
Wait. You're again going too fast. Slow down.
Oh, sorry, sir. Okay.
No, that's okay. That this is why we are here.
Mm,
I want
mm,
you to practice. I can practice whole day. It doesn't benefit you. I want
mm.
now. You will not forget. Um, you said he had pain all over. Shouldn't you
Uh,
use
diff
another term?
diffuse abdominal pain.
No.
Like,
Abdominal pain is a subjective complaint. Can you tell me now that I have abdominal pain?
uh, no, sir.
You
Like,
can't. But you can
no.
tell me whether I am tender,
Tenderness, yes.
which is a physical finding.
Mm,
So
mm.
once again, we are all talking about selecting the right term.
But,
So on physical examination, you should have said that his vital signs were normal. He had no fever particularly. Blood
mm,
pressure was 110/70 or whatever. Heart rate was so and so. Vital signs always come vital first.
mm.
His head and neck and cardiopulmonary examination were normal, if it was normal. Abdominal examination showed diffuse tenderness across all quadrants of the abdomen. Does it make sense?
Yes, sir.
Right? What else should you be telling
Yes,
me?
sir. Sir, mm,
Anybody can
rest of
help.
the
Those who are
symptoms,
watching can help.
uh, all of the rest of the systems were also unremarkable, like
You
his
you haven't
neurological.
told me the you haven't told me the most important part. Rectal exam.
Okay,
I'm
but
sure you learn in medical school that rectal
mm,
examination, nobody does it, unfortunately, but it is essential. And if you tell the program director that you need a rectal examination, he'll be more than happy because it is a lost art. My professor in
okay.
surgery many years ago used to tell us, because we were all reluctant to do a rectal exam. So he said to us, and I still remember, that if you don't put your finger in the rectum, you're putting your foot in the rectum. See the message? It is that important. So you should have said that the head and neck examination, cardiopulmonary examination, lymph node examination was normal. Abdominal examination showed diffuse tenderness across all quadrants, and rectal examination was normal. That's all. And bowel sounds were normal, or something like that. That makes it a complete picture. And rest of the exam, he had no edema, he had no cyanosis, all that. Within 1 minute, you can project a physical examination. Now you can go to the lab. So what happened?
So when his first labs came in, the thing that feared that was most alarming was that his hemoglobin was 3.9 and his hematocrit was around 15. and after that, his white counts were normal, and his platelets were also decreased. It was around 100K. But yeah, the hemoglobin was the main primary concern in that. So, in response, in order to tackle with that, he was given two transfusions.
No, not
Uh,
yet, not yet. If
Not yet.
hemoglobin
Okay.
is 3, forgive me for interrupting many times, but I want you to
No, no, sir.
understand.
It's okay. It's okay. Yes,
It's very important.
it's helpful.
If you tell me that this chap has hemoglobin of 3, what else should I know at that time?
Sir, apart from it, his peripheral smear, like his picture of his
Remember, we
MCV.
call it CBC.
Hmm.
C
Yes, sir.
stands for complete blood count. CBC. You have told me only incomplete blood count. You haven't told me his MCV. You haven't told me his MCH. What kind of anemia does he have?
Sir, he had a microcytic picture initially,
Micro.
his yes, sir. His hemoglobin was sorry, his MCV was less than 70. I don't know the exact figure, but it was definitely less than 70, and we that's why we started off with him with like there was a discussion also that should he be given iron therapy or not after the transfusion. But since he was a labor worker, so he couldn't afford that. So we had to, look for other options. But the surprising thing for us, sir, was when we even after we gave him that transfusion, like even after two transfusion, his hemoglobin didn't trend upwards, like the way it should ideally be. Like on repeat when we repeated the labs again, his hemoglobin was again at around 4.4, 4.5, near about
Now,
that.
if you give
So,
somebody with a hemoglobin of 3, 1 unit of blood,
mm,
how much hemoglobin should rise
sir,
after 1 unit?
around 0.8 to 1,
Correct.
0.8 to 1 unit.
But it did not.
He did not.
Okay. Good.
So that raised us a concern for if there is some active bleed in the patient, like any kind of occult bleed that we may not have
Okay, then
ruled
let me
out.
stop you
Or
here. Let me stop
so
you here. Why I raised the question of rectal exam.
yes, sir.
Now you know why.
Yes, sir.
Correct? If he was bleeding
Yes, sir.
slowly at that time, a finger would have picked it up.
Yes, sir.
That's why it
Yes.
is important to be a clinician. You have to know all this. Don't wait for just because nobody does it, I'm not going to do it. You did very well. So continue. What happened then?
So, sir, his endoscopy was performed. He got an upper GI endoscopy, and that did not rule out. That was inconclusive. Like that did not have any significant findings, which was related to the case. After that, sir, and the so this case, why it was a dilemma, because it was a clinical versus an ethical situation, because we could not expose the patient to unnecessary testing also, because he was from a very poor background. So we had to consider his basically his economic status also that way. So after trying out a few tests, what happened was when everything started coming out negative, for some reason we
What is wait. What is everything?
Oh, so basically, sir, when we were trying to rule out iron deficiency, like the causes of iron deficiency, and we were trying to rule out different causes, that what could be causing him, what could be causing the deficiency in him. We couldn't pinpoint anything based off his labs or his imaging. Like he got his ultrasound done,
What
chest.
labs and imaging are you talking about?
Sir, it was mostly it was general labs. I mean, we did complete we did a complete blood workup. Like we did his CBC, and then apart from that, we checked for his iron stores also. They were also depleted, and then he also got.
You have now established that he is bleeding somewhere. Most likely.
Yes, sir.
The commonest cause of microcytic anemia is bleeding. If it was a woman, it would be menstrual. But if it's a
Pregnancy.
man,
Oh, sorry,
it has
menstrual.
to
Yeah.
be you have to identify the source of bleeding. So you did an EGD, upper endoscopy, didn't find anything. So my guess
Nothing.
is You did for the lower endoscopy. Did you?
Sir, I actually that part I don't. To be very honest, I don't remember that part how it framed out exactly. But we did an ultrasound for sure. The ultrasound also didn't show
Ultrasound of
anything.
what? Wait.
The abdomen,
What,
sir. Ultrasound of whole abdomen was
what are you
done.
looking for?
Sir, sir, specifically, it was looked for his spleen and for like they were looking for
Why
any
spleen?
splenomegaly.
Wait. Are you in some sort of a competition with me that you are talking so fast? Slow
Sorry,
down.
no, sir, sorry.
Slow down,
Sir,
please. So what are you looking for in ultrasound?
sir, any signs of any either like we're looking for splenomegaly or any signs of any blood pooling or blood collection?
Is there a clinical situation where this can occur? Do you have something in mind?
Uh,
No.
no, sorry.
You have established so far that he probably has a bleeding disorder, but you haven't gotten to his small bowel, you haven't gotten to his large bowel, but you're going for an ultrasound. Not that anybody will ask you all these questions. I'm just trying to make it more difficult so you understand that you need to be prepared. Questions, because the program director has the authority to ask you any question he or she likes. And there where your clinical acumen will be shown. So, since somebody wants to participate in this dialogue, anybody? Okay. Okay, then what happened?
So, sir, after that, he went to he was taken for a lower bowel endoscopy, and that came positive with occult bleeding. Uh, but still, they said that there was occult, like there was spots of blood found, and there were few ulcerations, but it was still again inconclusive that time. So after that, sir, we went back and we checked through his case again, and we took his history again specifically. What came out interesting on this time was when he was questioned about his diet. So what he told us was being since he was a laborer and the only thing that he could actually afford was eating just chapatis. So he would be for his every meal he would just be eating 8 to 10 chapatis, like wheat based chapatis, for twice a day. That was his complete lunch. Like he would have it with either with salt or water or something else, but that was it. So, and he had been doing it for quite some time. And then when we tried correlating his picture with it, a lot of his symptoms started out when we saw that he was on this diet. So he wasn't on this diet since earlier, but when he switched to this diet, a lot of these symptoms started coming up for him. And this was a new correlation that we got to know. Then we had like celiac disease in our mind, like the case of like celiac disease popped up. And after that, we thought about testing. Then, sir, again, the dilemma came of testing him or not, because we were like just so if we would have it tested, it would have to be from our pockets because he couldn't pay it for that. So my consultant at that time, he paid that money for the patient, but he just stopped all of his carbs. Like even in the hospital, he was getting carbs from the hospital diet. He cut down all of the carbs and he was completely given a no carb diet. And within a week, I would say his hemoglobin it jumped from around 4.6, 4.7 to around 6 something, 6.8, 6.9. And even like when we did his basically, when we did his screening for celiac disease, so that came in positive. But that patient, like, and it was a very rare case for us to see in such a low economic background status, someone suffering from celiac disease, and all of his problems stemming up from just his diet, like eating chapatis, as simple as that. So that was a
The
interesting
final
case.
diagnosis was celiac.
Yes, sir.
Okay. And then you put him on a gluten free diet, and
Yes, sir.
it is a curable disease.
He
Now,
started recovering, yes, sir. But we didn't have biopsy to confirm it still. He hasn't gone biopsy.
you need a biopsy?
No, sir.
Well, ideally, yes.
Yeah,
Ideally.
yeah.
But we are not in an ideal world. And
Mm,
you mentioned
true.
several times about the economic problems. So it is important to understand that economics many times drive um, our behavior, clinical behavior. But it's a very good case. You can polish it a little bit more to present. It's a good case. I would recommend that you polish it a little more and remove all the abstractions into it. There's a lot
Yes,
of
sir.
noise. And prepare properly. When you present a blood count, remember the word C is the complete blood count. So telling me hemoglobin and platelet is not enough. You have to tell me about MCV, MCH, peripheral smear. It would be wonderful if you told me that you went to the lab and looked at his peripheral smear with your pathologist.
Okay.
Don't you think it would impress me?
Yes, sir.
Right? Nobody does it. You have to show that you are different than an ordinary person. So when I was a resident your age, we had a rule that you never present a case without looking at a blood smear. So I spent a lot of hours in the path lab to learn. And even today, I can read a blood smear just like a hematologist because of the practice. So learn that. And the one question which I ask, and many program directors ask you after you present the case, what did you learn from this case? You have an answer?
Yes, sir. So, sir, my learning point is rather, I believe, not just simply academic. Like when we see medicine as a subject and as a branch or as a profession, a lot of the times we feel like every situation or everything can be monitored academically, or the things that you learn in your med school or in your books or during your exams, and but in real life situations things tend to be very different that way. So the practical application needs to be on par with your education. Like only the education stuff and studying about is not relevant, but knowing how the condition of your patient is and viewing a holistic picture and working around that is way more important to improve your patient's condition rather than what you know or what you rely on always.
So you're adding a lot of elements, poverty, big element in this case, diet. So dietary history should have been mentioned upfront. Why would it come later? You should have told us upfront that his diet consisted of 10 chapatis a day without vegetables or fruits. That would have been a wonderful statement. You ultimately diagnosed celiac. So did he have any other signs of celiac disease, like malabsorption? That's why I asked you about weight loss. You said he was cachectic. Did he have any other signs of celiac disease? What other signs, if I tell you that Mr. Smith has celiac disease, examine him for 2 minutes, what will you do? Well, these are the questions they will ask you.
Sir,
2 minutes, you
so
got 2 minutes.
when Okay, so sir, when I'm looking at person at the physically, there can be, like you said, sir, malabsorption. So the patient would look lean and thin. Apart from that, anemic. So the patient would look pale, and so there can be associated symptoms with it. Sorry, associated clinical features like dermatitis herpetiformis, where the patient may develop like painful sores and blisters on the lower
No, in
limbs.
your history, you should have mentioned that there were no skin lesions.
Okay,
Then I know what you're looking for. You want to
okay.
impress your examiner that you know this stuff. There's a saying in medicine, what the mind doesn't know, the eyes don't see. Think about that. What the mind doesn't know, the eyes don't see. So if there is a dermatitis herpetiformis there, but if you didn't know the connection, you would miss it. That's what physical diagnosis is. And before I forget, I want you to think about what I have been calling Plan B. You remember I told you that if you don't match, what is your alternative? There are plenty of them. MPH, MHA, quality and safety, certificate in statistics, certificate in epidemiology, certificate, not just attending a course, but you need to get a certificate. There's plenty of time for you to do that. One thing I want you to consider is doing an MRCP. You know what an MRCP is? Member of the Royal
Yes, sir.
College of Physicians. You are
Physician.
eligible. It is a
Uh,
part one and part two is a written exam. You can do it in New Brunswick at St. Peter's. We are the center for MRCP part one and two. There is a clinical exam afterwards. We are not the center for that. You have to go to another country. There is no center in US. You have to go either Far East, India, Pakistan, Bangladesh, Singapore, Malaysia, the places like that. It's very hard to get in because there's a long queue. But consider doing MRCP. There are free videos of MRCP on YouTube. So what I would recommend that you consider watching every video there is. There are about 50 of them, good ones. And then there is a Stanford 25. Stanford University has a collection of videos that are outstanding. I know the people who made them personally, they're my friends. I recommend that all of you do that and make sure that during the interview that comes up. You should make a statement that I have watched Stanford 25 X number of times because clinical skills are lacking in our candidates. So you need to show them that you are interested in clinical skills. So those are the things in Plan B. There are many more. You have any immediate questions? We are 7 minutes away from 1 o'clock. Letter of recommendation, we talked about it. Nobody should charge you, but I know they do. That is illegal and unethical in my mind. So your letter of recommendation is going to be your portfolio. Make a nice, attractive, pleasing, accurate portfolio. Write down everything you see. Now this case should be in your portfolio with details. That would go a long way, along with the blood smear, along with the HLA antibody and all that. So you can make a big case out of that. Has anybody looked into the Maximo Nivel? Any one of you interested in that? Spanish?
Sir, I've emailed them. I'm waiting for their replies and stuff. Basically,
Yeah.
I reached out to them via emails.
Good.
So I was looking for them for if they have like what are the opportunities that they're providing and how their timeline is basically. So I'm waiting for that.
They start every Monday a new class.
Oh,
Every
okay.
Monday. So it is up to you to do that. I also inquired about the visa. If you have an American tourist visa, the Peruvian government will automatically give you a visitor's visa. And they will pick you up at the
Oh,
airport
okay.
and leave you back at the airport. It's a very, I haven't done it, but from what I see, it's a very hospitable site. And I know the director, so if you have any difficulty, send me an email. They are
Okay, sir.
anxious to start the program. I'm anxious to start, and I think it will do you a lot of good. Lot of good. Not now, even in the future. Learning this correct language of your patient is very important. Um,
Okay.
anyone has any question? We haven't discussed about visa. I think the US government has solved the problem by not giving you H1. Don't go after H1. It's in limbo. Right now, Trump has stopped all the H1 visas for Indians. And I don't know about Pakistanis, but they have stopped it. And if you go for H1, you will not get fellowship because no fellowship sponsors H1 visa. J1 is the right visa for you. And yeah, there is a 2-year clause. You have to get out of the country, go back to your mother country. It's not a big deal, frankly. It's okay. I did it for 3 years. I was in India back, and the best thing I ever did. Have you all written your personal statement? Has anybody corrected it? If you want to send it to me, I'll be happy to look at it and give you a feedback. And you should reach out to an English teacher who can read your language and make sure that there are no typos, spellings. Nothing is worse than a spelling mistake. So English teacher, in my mind, I still have an English teacher for my document. When I write an important document, I send it to her, and she sends me back with a little correction here and there. It's very nice, very nice, very small cost, very small cost. Anybody has looked at Toastmaster?
Yes,
No?
I'm looking at it. I'm trying to
Okay.
find. I'm right now in New Jersey. I'm trying to find the nearest ones and looking into the fee and stuff.
Well, there is one at Rutgers,
There's one at Rutgers,
Highland
but
Park. They meet
but
in Highland Park.
I'm trying
The
to figure
university.
out if they allow me. Like I have to pay a fee and then I
There
can
is
like
a small fee, yeah. There is a small fee. It's called, I think they call it membership, but it's not much. It's
okay.
relatively, I would not say cheap, but inexpensive. Yeah. But it's amazing how people are transformed with that. Besides, you develop context. You'll probably meet a Chinese professor or a Cambodian scholar. That is the group you want to associate with, not just your classmates. There's
Sure.
nothing wrong with your classmates, but you need to reach out to others. And anybody has looked at MPH? Why not?
Professor, already doing the MPH, and regarding the languages, I am definitely going to do both of them. But about the Toastmaster, I think I will start in 2 months. And the Spanish language, I have to figure out about a visa. So if it's not available, then
I already did. And they inquired for me,
uh,
and they said that if a Indian or Pakistani graduate carries a visitor's visa to US.
actually, I have a little bit different status right now.
Oh, I see.
So basically, I have to figure it out on that way. I am on student visa, but I am on change of status. So I don't have stamp of particular visa, so I cannot travel.
Yeah, okay. Yeah, I'm sorry I can't advise you on that because
Yeah,
I
so
do not
but
know much, but
definitely I will consider it online if it's possible, or if somehow if I will get solve that issue, then I'm looking forward to it. Toastmaster, I'm planning as soon as possible.
for the Spanish thing, I would recommend that you go there. You go
Sure.
there. It is not just a language. Language you can learn anywhere. It is the culture. You will
Also,
live
yeah,
with a Spanish family. You will dance with them. They have a dance class.
yeah, definitely. It will
It's amazing what they have done. And it is in 3 countries. And the best customer they have is Department of State. So if you are appointed as an ambassador to, let's say in Guatemala, you have to go to the school first to
right.
become fluent. So there is a lot of things, but go outside the box and try to do those things, and your application will come up.
I will solve.
Um, Go on. If you have gaps in your CV, be prepared to explain. There's nothing wrong with a gap. If somebody had pregnancy or mother was sick and you took leave for a year, that is commendable. That is not a gap. But you need to be able to explain why and what did you do during that time. And you should always spin a positive note that I'm so glad that I was able to take care of my mother during her last days. Nobody can question that. Nobody. Because that tells you about your character, tells me about your character, that you are willing to give up your career for your mother. That's wonderful. And don't forget the bedside skills. Don't forget the IHI curriculum, the Institute for Healthcare Improvement, quality and safety. But if you do get a certificate, without certificate, it has no meaning at all. There are small modules which you can do in 1 hour. I think you have to do 12 or 10 or something. There's a small fee, and then you write a national exam like a board certification. And if you do X number of modules, you are board certified in quality and safety. I would go for that. Absolutely, you cannot make a mistake. Okay, we are 1:00. Any questions? We have one more seminar left next week. I hope more people will come. I'm sort of disappointed that people are not using this. Maybe it is not known. But you need to give me some feedback. How was it for you? So I haven't received any feedback. If feedback has a lot of value for me and for you for the future webinars. So you need to tell me whether this was a useful thing, whether I should modify it, whether I should keep it at 5 or make it 4 or 6. But you need to tell me that.
Dr. Kothari, I think we're very grateful for the seminar because, first of all, I was actually talking to one of the residents at the conference in RP, and he was from St. Peter's as well. And I mentioned it to him. I'm like, we as an IMG community, there is no one who's speaking for us and someone who's coming ahead and actually taking the initiative to teach us and guide us at the right moment. I feel I think what I can make out, Dr. Patel and Dr. Singh right now, in the ones who are there right now, are in a process where we are waiting. We have applied. We are match applicants this cycle. So I think the reason might be because we are trying to cater this to maybe the wrong audience, not the entirely wrong audience. There are a lot of people waiting for interviews right now. Some might be caught up with that, but the amount of guidance and the initiative we're taking, we're very, very, very grateful for it. I just wish I got this when I started my journey.
A lot of people have told me that. A lot of people have told me that. Because there is so much ignorance really. But see, you don't realize that how good you can be and how good you are. But as you said, there is no spokesperson for this community. There is no organization which speaks. Once you enter the residency, a lot of people will speak for you. AMA, ACP, everybody. But until then, you are looking through the window. And that is pathetic. That should not be the case. You know, you are a talent which America does not have. And my goal, when I started, I should have started 20 years ago, but my goal now is to speak for this community, advise them appropriately, I hope, and get them to the right place in time. Good news is that the country is understanding that. That's why they are beginning to give licenses to internationally trained physicians, ITGs. So if you've done an MD in India, you're eligible. So there are many. I have had recruited dozens of Indian MDs and MRCPs in my program over years. And they're wonderful because they are more knowledgeable, more clinicians than ever one can imagine. Because now you are combining the British Indian training, Pakistani training with American training, which is an ideal combination. One alone is not sufficient in my mind because I came after graduating from medical school, I came straight to America. So I had all American training for 4 years. And then I went to UK. And I had a shock of my life. I knew nothing clinically, but I fixed it. I think I fixed it. And combining both. That's why we have this Royal College coming at St. Peter's every 6 months. That is the reason we have Royal College coming in and conducting their PACES exam for the past 12 years now. It's working very successfully. So spread out your wings, do other things. Hopefully you will match. So, but even after matching, what I have told you will be useful. Okay, I wish you all the best. We'll see you next week.
Thank you so much,
Thank
Dr.
you, sir.
Kothari.
Thank you.
Thank
Happy
you for a lot
Thanksgiving.
of your insights, sir, and like
Yeah.
all the like it was. I know it was like you were like it must have been felt like nitpicky or something, but all of the things that you said were pretty important because those are the things that we don't tend to pay attention to. So thank you so much for that.
Told you on first day when we met that my goal is to make you unhappy at the end of this. And I think I have successfully done it. It may sound harsh, it may sound hypercritical, but it is better that I criticize you now than the program director puts your application in the garbage. Because that's the alternative.
That is true.
And there is no reason why you should be. You are very good. You are very good. So stay that way, apply yourself, and you will get. And please, when the match comes, do let me know what is the result. I do like to know.
Definitely,
Okay,
sir.
all the
Thank you
best.
so
I'll
much.
see you next week. Okay,
Thank you,
thank
sir.
you.
Thank you, Dr. Kothari, for everything, for the minute detail. You taught it goes really a long way. Like people, like person like me, I'm miserable, and I came here. And since 2 years, I was around the St. Peter's, but I didn't knew about it. And I as soon as I came to know, I just jump in, and it was really helpful the program because no one in this country, even in IMG, like no one is like supporting like this, and not even we. It's very hard to get even observership over here, or like it was very difficult, but the journey became very smooth right now, and I am also fixing my things day by day, like becoming better. And I've always learned from your website, CV, and everything, and it was very very helpful as an IMG. And it just gives us a hope, like I just forgot that I am the doctor since this many years, and I came here. And as soon as I went inside the observership, it was very great experience. And it reminded me I'm not here for flipping burgers, as Miss Lynn says. And immediately right now I am starting aligning my things. Thank you very much.
You have to think broad. You have to think deep. You have to think wide. You are not just an MBBS from Ahmedabad. You are more than that. And if I could do it, why can't you?
Yes, that's
I came as an intern. I had no knowledge of America, nothing. You know more than I ever knew. But I was able to get through the ranks and went all the way to the chairmanship, professorship, everything what one would want.
yeah, I have decided I will give whatever it takes, but definitely I will be one day.
That is the spirit.
Obviously.
That is the spirit. And you will get there. I guarantee you, you will get there. Okay, thank you. Thank you all. Have a good day.
You
Thank
too.
you.
Thank you, sir.
Thank you.
Bye.